Welcome back to the deep dive. We are opening up the source material today on, well, a true mechanical puzzle. The radiographic requirements for imaging the shoulder girdle.
Yeah, we're talking the whole complex.
Yeah.
Proximal humerus, shoulder joint itself,
Ah.
AC joints, clavicle, scapula, the works.
It's perhaps one of the most dynamic and maybe challenging complexes of bones and joints to really visualize clearly.
Absolutely. And our goal in this deep dive, it's highly focused. We want to move beyond just knowing the anatomy
Right.
and really understand the technical choreography involved. Like, why does missing the positioning by just a few degrees, why can that render an image diagnostically useless?
That's the core question. This really is a masterclass in applying that anatomical knowledge directly to physics, isn't it?
It is. So maybe let's nail down the foundation first. A couple of quick but crucial anatomical anchors we'll keep coming back to.
Seems good. Where do we start?
Well, what's fascinating here is how image clarity often hinges on relating the body to these, well, pretty small features. First, let's just confirm the lateral thickened end of the scapular spine.
Okay.
That's the acromion.
Got it. The acromion.
And then, if you look at the superior border of the scapula, you'll find the scapular notch.
Right. The notch on the top edge.
Exactly.
Yeah.
Keeping those two landmarks sort of in the back of your mind will really help anchor the discussion as we talk positioning for specific views.
Okay. Landmarks established. Now, procedural guidelines. Patient prep seems like the first hurdle.
It does, and it's basic, but gosh, it causes so many retakes. You absolutely must remove all radiopaque artifacts.
All of them. You mean everything.
Everything. We're talking jewelry, of course, but also bra hooks, buttons, zippers near the area. Anything that casts that dense white shadow on the image.
Right. Anything near the anatomy of interest.
Exactly. That focus on just pure image quality, it runs parallel to patient safety and comfort.
Which is critical. I mean, while we're striving for this incredible precision, we have to remember these procedures, they can be done upright or recumbent.
Yeah, absolutely.
Right.
It's based entirely on what the patient can tolerate, especially in trauma situations. Comfort often dictates the approach.
And on the safety side, what do the sources emphasize there?
Rigorous adherence to proper collimation is key.
So tightening that beam right down?
Tightening the beam, using optimum technique factors, the right KVP and EVP, and whenever it's necessary and possible, using lead shielding, placed between the gonads and the radiation source.
Okay, standard radiation protection practices.
Standard, but crucial. And then there are the breathing instructions we give the patient. Those are also critical.
Right. Now, is it safe to assume, sort of like with chest x-rays, that we generally want suspended respiration for most shoulder views?
Yeah.
Or are there, complications specific to this area?
That's a good assumption. You're right, most exposures do require suspended respirations, minimizes motion blur. However, there is one key exception, and it really illustrates the physics involved quite beautifully.
Oh, which one is that?
It's the transthoracic lateral projection.
Transthoracic. So shooting through the chest. Why is that one different with breathing?
Exactly. Because you are shooting through the chest cavity to see the shoulder structures, particularly the proximal humerus, on the other side.
Okay.
To get clarity on that humerus, we actually want the lung markings and the rib details to blur out. We want them to become a sort of uniform gray background.
Ah, I see. So how do you achieve that blur?
You use a specific breathing technique. This means setting a low milliamperage, a low MA with a relatively long exposure time.
Longer time. Okay.
And during that long exposure, you instruct the patient to breathe shallowly and gently. Not a deep breath, just quiet breathing.
And that motion blurs the lungs and ribs.
Precisely. The constant, gentle motion of the lungs and ribs blurs them out because of the long exposure time, while the shoulder itself, hopefully held still, remains sharp. It's a neat technical trick using time itself as a filter.
That is a great technical nugget. Okay, so prep sets the stage. Breathing instructions have their nuances. But the real skill, especially for the core AP projections, it really comes down to one thing, doesn't it? Rotation.
Rotation dictates everything in these views. It's the difference, like I sometimes say, between seeing a highway sign clearly or just seeing the metal back of it completely changes what information you get.
So let's unpack those fundamental AP views, starting with external rotation.
Okay, the AP projection external rotation. For the setup, the patient usually flexes their elbow just slightly.
It's just a bit.
Rotates the arm externally, so turning it outwards, and supinates the hand, like palm up or forward.
And the really specific instruction, the key part.
The most specific instruction is that the humeral epicondyles, those bony bumps on either side of the distal humerus near the elbow, must be placed parallel to the IR.
Let's pause there. The IR, for everyone listening, that's the image receptor, the plate or the digital sensor capturing the X-ray image.
Correct. So when you achieve that perfect parallel position of the epicondyles,
What do you see? What's the goal?
what results is a beautiful profile of the humeral head. And crucially, the greater tubercle, that larger bump on the humerus, is clearly profiled on the lateral or outer aspect of the humerus.
So seeing that greater tubercle laterally tells you, yes, I got the external rotation right.
That's your visual confirmation. Exactly.
Now, if we flip that rotation, we get the AP projection internal rotation.
Right. So instead of the palm facing up or forward, the patient rotates the arm internally, turning it inwards,
How far?
usually until the back of their hand rests comfortably on their hip or upper thigh.
Okay.
And this positioning naturally forces the humeral epicondyles to become perpendicular to the image receptor.
Perpendicular this time, so a 90-degree difference from the external view at the elbow.
Exactly. And that, well, seemingly subtle shift in elbow position, it dramatically changes the clinical information available on the image.
So what's the image goal here? What are we trying to see?
Now, the goal is to bring the lesser tubercle, the smaller, bump into profile, and it should be pointing medially towards the body's midline.
Pointing medially. And why is seeing the lesser tubercle important?
Well, this view is essential for looking at things like certain types of rotator issues, maybe posterior dislocations, or injuries affecting the anterior part of the shoulder. It just gives you a completely different perspective.
Makes sense. And for both of these primary AP views, external and internal rotation, the CR placement, that stays the same.
Yes, the central ray placement is consistent. It's perpendicular to the IR, entering the patient about 1 inch inferior to the coracoid process.
And just to place that landmark again for everyone listening, the coracoid process is that little kind of hook-like bony projection you can often feel on the front of the shoulder.
That's the one, a key landmark for centering.
Okay. And there's one more AP view, the neutral position.
Correct. And the AP neutral position view is, well, it's reserved almost exclusively for trauma situations.
Meaning when the patient can't move their arm.
Exactly. If the patient absolutely cannot rotate their arm due to pain or injury, you leave it alone. You shoot it as it lies.
So the arm's just hanging naturally.
Often, yes, just in a neutral hang. And that typically places the epicondyles at roughly a 45-degree angle relative to the IR. It's not ideal anatomically, but the priority shifts entirely.
To patient comfort and just not causing more harm.
Precisely. Preventing further injury is paramount in trauma.
That distinction is really key. You move beyond trying to manipulate the patient for the perfect view and start manipulating the beam or the environment instead.
Exactly. Which takes us perfectly into those specialized views, the ones designed specifically to maybe diagnose dislocations or to accommodate severe trauma where movement is impossible.
Where should we start with those?
Let's revisit the transthoracic lateral, or the Lawrence method. We mentioned the breathing technique.
Right. The long exposure, shallow breathing.
Well, this view is basically non-negotiable for trauma patients who physically cannot rotate or abduct the injured limb.
So if they can't lift their arm out or turn it, this is the go-to for a lateral view.
It is. And the cardinal rule here is simple and absolute. Do not move the injured limb, period.
Okay, so how do you get the shot without moving the injured side?
You work the uninjured side. You ask the patient, if they can, to elevate their unaffected shoulder as high as possible.
Lifting the good arm up.
Lifting the good arm up and maybe slightly forward, basically trying to pull the uninjured shoulder's shadow up and out of the path of the X-ray beam aimed at the injured shoulder.
Trying to get it out of the way.
Exactly. The central ray is typically perpendicular, entering the midcoronal plane right at the level of the surgical neck of the affected humerus.
But what if the patient can't lift that other shoulder very high? What if they're sort of level?
That's a great point, and it happens often in trauma. If the patient's shoulders end up being in or close to the same horizontal plane,
Then what?
then you must angle the CR. You angle it 10 to 15 degrees cephalad, meaning angled up towards the patient's head.
And that angle helps project the shadow of the uninjured shoulder upwards, clear of the injured one.
Precisely. It's an adjustment based on the patient's presentation. A great example of needing to adjust the physics, the beam angle, to compensate for the patient's physical limitations.
Really adapting the technique on the fly. Okay, what's next in specialized views?
Next up, an incredibly powerful diagnostic view. The PA oblique, which most people know as the scapular Y.
Scapular, why?
It's named quite literally because, on the image, The acroman and the coracoid process, along with the main body of the scapula, converge to form a very distinct Y shape.
Okay, I can picture that.
And this view, it is practically mandatory for checking shoulder dislocations. Its diagnostic power is immense.
Okay. The positioning sounds like it might be complex, though. How do you set the patient up for this one?
It takes a bit of practice. You have the affected shoulder placed closer to the image receptor. Then you rotate the patient's body into quite a significant anterior oblique position.
How oblique?
Usually around 45 to 60 degrees anterior oblique. So the patient is facing the IR, but turned quite sharply.
45 to 60 degrees. That's a lot.
It is. And here's the interesting trick. The actual arm position itself isn't critical for this view.
Really? The arm doesn't matter.
Not the primary focus. The main focus is on palpating the scapula, feeling its flat surfaces, and positioning the patient so that the body of the scapula is perfectly perpendicular to the image receptor.
So you're aiming for a true lateral profile of the scapula itself, regardless of where the arm ends up.
Exactly. You want that Y shape formed by the scapular processes to be seen clearly.
And the diagnosis, you said it's immediate based on that Y. How do we read it?
It's beautifully simple, visually. If the shoulder is normal, not dislocated, the round humeral head sits perfectly superimposed right over the junction, the center of that Y.
Okay, head in the middle of the Y equals normal.
Right. But if the shoulder is dislocated anteriorly, which is the most common type by far,
Where does the head go?
the humeral head is seen dramatically below the coracoid process, the anterior arm of the Y.
Below the coracoid. Got it.
And if it's one of the rarer posterior dislocations, the head is seen below the acromion, the posterior arm of the Y.
Below the acromion for posterior. Wow.
Yeah, that tiny bit of bony geography on the image gives you instant, often life-altering diagnostic clarity. It's a fantastic view.
Incredible how positioning reveals that.
All right.
Okay, moving on from dislocations. Let's target some of the outliers. Views for the smaller but still really important structures in the girdle, like the AC joint maybe, or...
Let's start with another view for the shoulder joint itself, but from a different angle. The inferosuperior axial. This is another variation, sometimes called the Lawrence method.
Inferior-superior, so beam coming from below going upwards.
Exactly. This view is primarily about getting a good look at the humeral head and the glenoid cavity, the joint space, from underneath.
How's the patient positioned? Arm abducted.
Yes, if possible, the arm is abducted out to the side, ideally to a right angle, 90 degrees, and typically placed in external rotation if the patient can manage it.
Okay, arm out. What about the CR?
The CR beam is horizontal, so it's parallel to the floor.
Okay.
But you need to angle the tube medially towards the patient's midline. The angle required is usually between 15 and 30 degrees medial.
Why the medial angle on this one?
That angle is crucial. It helps project the joint space clearly, separating it from the overlying shoulder mass, and it also compensates for the degree of arm abduction.
Ah, so the angle changes depending on how much the arm is abducted.
Generally, yes.
Yeah.
The rule of thumb is the more the arm is abducted, closer to 90 degrees, the greater the medial angle you'll likely need, maybe closer to that 30 degrees.
I see. And where does the beam enter?
The beam enters the axilla, the armpit basically, and passes straight up through the region of the AC joint and shoulder joint.
Got it. Okay, now let's hit the AC joints specifically. The AP AC joints or the Pearson method, this is the one that involves weights, right? That's unique.
That's the one. It's quite distinct because it's the only routine projection in this set that requires separate exposures under different conditions.
Separate exposures. How so?
You do one exposure with the patient just standing normally, without any weights, just a baseline view.
Okay, baseline first.
Then you do a second exposure, same position, same technique factors, but this time with equal weights affixed to the patient's wrists or held hanging from their hands.
Weights. Why the weights? What are they doing?
You're intentionally putting stress, a downward pull, on the shoulder girdle, specifically targeting the acromioclavicular joint capsule.
Trying to pull it apart.
Essentially, yes. If there's a separation or instability in that AC joint, those weights will literally pull the clavicle and acromion slightly apart, making the widening of the joint space glaringly obvious on that weighted image compared to the non-weighted one.
Ah, so it highlights instability.
Exactly. It's a critical comparison tool for orthopedists assessing AC joint separations. Crucial that the shoulders are level for both exposures too.
Makes sense. Okay, angles come back into play when we image the clavicle, don't they? Specifically with the AP axial clavicle view.
Yes, they do. And this is another area where technical mastery really shows. We use an angled beam here to project the clavicle upwards, lifting its shadow clear of the ribs and lung structures that lie just beneath it.
So angling the tube cephalad. towards the head.
Cephalad angle, correct. If
Hmm.
the patient is lying supine on their back, the typical CR angle range is 15 to 30 degrees cephalic.
That seems like a pretty wide range, 15 to 30 degrees. How do you decide exactly how much angle to use?
You really have to assess the patient's body habitus, their thickness.
Thicker versus thinner patient.
Right. A thinner patient, an actinic patient, generally needs more angle, maybe closer to that 30 degrees, to effectively project the clavicle up and over the underlying chest structures.
Okay, more angle for thinner patients.
Whereas a thicker patient, a hypersthenic patient, has more tissue mass naturally elevating the clavicle slightly, so they might only require 15 degrees of angle to get the same separation. It's a judgment call based on physique.
Interesting. And there was a breathing instruction specific to clavicle views too, wasn't there? Different from the shoulder.
Yes, good catch. Unlike most shoulder views needing suspended inspiration or just suspension, these clavicle exposures, both the standard APPA and the AP axial, should be made at the end of full exhalation.
Exhalation. Why exhale?
Pushing all the air out helps to depress the rib cage and flatten the chest cavity slightly. This gives you a bit more contrast and helps get the clavicle clearer with less underlying lung shadow.
Little tricks of the trade. Okay, our final specific view area, the lateral scapula. And this one has two very different arm positions depending on what part of the scapula we want to see.
That's right. The arm position is key here and totally changes what part of the scapula is best demonstrated.
So, option 1, if we want to see the processes.
If the primary goal is to clearly demonstrate the acromion and the coracoid processes the arms of that Y we talked about,
Yes.
then the patient typically flexes their elbow and places the back of their hand on their posterior thorax, basically on their lower back.
Hand on the back. How does that help?
That position pulls the humerus anteriorly and inferiorly, moving it out of the way so it doesn't superimpose over those superior scapular processes.
Okay, clears the view for the acromion and coracoid. What's option 2?
Option 2 is when you need to see the main body, the scapula itself, the flat blade part.
How do you position for that?
For the body, the patient needs to perform a big stretch. They either extend the affected arm straight upward, often resting the forearm on top of their head,
Arm up overhead.
or they bring the affected arm across their upper anterior chest, reaching towards the opposite shoulder.
And the goal of that movement.
The objective in either of those setups is exactly the same. Get the shaft of the humerus out of the way so it doesn't overlap the main body of the scapula. This allows us to profile the bone's true lateral aspect, seeing the blade edge on.
Two distinct positions for two distinct parts of the same bone. Fascinating.
It really highlights how positioning is tailored to the specific clinical question.
Okay, wow. We've covered a lot of complex positional instructions there. Now, let's try to synthesize this. After all that careful, sometimes complicated positioning, how do you, the radiographer, know you actually nailed the shot? What are the key evaluation criteria you check before sending that image off to the physician?
Right, this is where we connect all that positioning effort back to the visible anatomy on the final image. It's the quality check.
So for that fundamental AP external rotation, what's the visual proof?
You must confirm that the greater tubercle is seen clearly in profile on the lateral aspect of the humerus. That is your non-negotiable check mark. It proves the epicondyles were indeed parallel to the IR.
Got it. Greater tubercle profiled laterally, and conversely for the AP internal rotation.
The check there is seeing the lesser tubercle in profile, and critically, pointing medially towards the body. If it's not quite in profile or not pointing medially, your internal rotation wasn't quite sufficient.
Lesser tubercle profiled, pointing medially. Okay. What about that tricky trauma view, the transthoracic lateral?
For the transthoracic, the key evaluation point, besides seeing the humerus clearly, is ensuring the unaffected clavicle and humerus, the structures on the side lifted away, are projected cleanly above the shoulder closest to the IR.
So no overlap from the good side onto the injured side you're trying to see.
Exactly. If those unaffected structures are overlapping your target anatomy, the image probably isn't diagnostically clear enough. Might need to adjust that angle or positioning.
Makes sense. And lastly, achieving that perfect lateral scapula view. What confirms success there?
The definitive sign of success is seeing the lateral, axillary, and medial vertebral borders of the scapula perfectly superimposed on each other,
Stacked right on top of each other.
like two edges lined up perfectly. That superposition proves you achieved a true, pure lateral profile of the scapula body, not an oblique view, which can hide or distort pathology.
Perfect superimposition for a true lateral. Excellent.
So you can see we've really moved far beyond just listing anatomical parts today.
Definitely. We've really examined the highly detailed diagnostic choreography, as you called it, that's required to visualize this incredibly mobile and complex shoulder girdle.
And the critical takeaway, I think, the thing to really remember is that this precise positioning, it isn't just, academic adherence to a textbook rule.
No, it directly impacts diagnosis.
It absolutely dictates whether a critical diagnosis like a subtle fracture or confirming the exact type of shoulder dislocation is instantly recognizable or potentially missed. That precision really is the foundation of good patient care in this field.
Couldn't agree more.
And, that necessity for diagnostic clarity, even when things aren't perfect, leads us to maybe a final thought for you, the listener, to consider.
Okay, lay it on us.
We briefly touched on another view, the Grashey method, which ideally requires a specific 35 to 45 degree posterior oblique position to really open up and profile the glenohumeral joint space.
The true AP of the joint.
Yes. Now imagine a trauma patient who simply cannot achieve that required 35 to 45 degree oblique position because of massive pain or the nature of their injury. The position is compromised.
Okay, happens all the time in trauma.
So in that situation, despite the necessary positional compromise, what do you think is the most important element or detail on that final imperfect Grashey image that a physician must still be able to discern clearly to make a useful assessment?
If the positioning isn't perfect, the priority probably shifts, right? Maybe away from perfect joint space geometry and more towards maybe seeing the fine bony trabecular detail
Amen.
to look for fracture lines, and also assessing the degree of overlap, even if it's not zero, between the humeral head and the glenoid.
Exactly. Even on a compromised view, assessing that bone texture for subtle breaks and understanding the relative position and overlap of the head on the glenoid can still reveal significant injury, even when that textbook open joint space view is impossible to achieve. It's about extracting the maximum diagnostic information from whatever image is possible.
Something to definitely chew on as you review your own sources and experiences. Great point.
Absolutely.
Well, that wraps up our deep dive into the shoulder girdle's radiographic secrets. We'll catch you next time for the next deep dive.